indeed my pleasure to be here and to introduce the speaker, Dr. Aravind. I think every year there is an outbreak, a big or small pandemic, a local cluster, anything, Aravind will be there because he's in the forefront of all the epidemics, and we have had enough in the last couple of years. So I think now COVID is more out of fashion, and now the in thing is influenza and its complications. But we have had several mimickers of influenza as well. So to talk about all this, the viral syndrome and influenza and other similar illness, today we have Dr. Aravind. Without much intro, I'll hand over the mic to him, and then we can have a good discussion, questions. Thank you. Over to you.
Respected Chairperson and senior physicians, I'd like to thank the organizers for this opportunity. So next 12 minutes, my job is to take you from AI to ILI. Okay. So basically, the problem is that prior to the advent of COVID-19, so majority of the ILI used to be, we had this ABC guidelines for influenza following this H1N1 pandemic in 2009. Then COVID came into the picture, and for the next 2 years, all the ILIs were, virtually the COVID-19. But then over the last 1 year, now this, since, the NPI have gone back, we are having a mix of, COVID-19 as well as all sorts of influenza. And basically, from the ground level, the PHC level, the casualties, the OPDs, etc., the problem that the clinicians are facing. So we have invested that much in molecular diagnostic, but still, a person is coming with fever and cough, what is the diagnosis is a challenging dilemma. So when we are looking at the surveillance definition of ILI and SARI, this all of us are familiar with this thing. So basically, if you're having a fever and cough and duration less than 10 days, can term it as influenza-like illness. And along with this ILI, if the patient is sick, is having dyspnea, we'll term it as severe acute respiratory infection. So in the Kerala context, if a patient is coming with a fever, sore throat, cough, etc., so these are the four main DDs that we need to consider. This is based on data of the circulating strains in Kerala of the last 1 year. So it could be SARS-CoV-2 infection, it could be influenza, it could be RSV, or it could be adenovirus. Adenovirus is a bit more easier because, there will be associated conjunctivitis as well. Okay, when you're talking about influenza, so it could be influenza A, H1N1, H3N2, or influenza B, or the last 1 year we have been having sort of a co-circulation of H1N1, H3N2, as well as influenza B. So this is actually the data from the WHO, the FluNet, that is the Global Influenza Surveillance Network. It's actually based on this data that, the composition of the vaccines for different seasons are compiled by WHO. Can see that when COVID was at its peak, that is in 2020, 2021, etc., the influenza activity across the globe was very less. This is because of the effectiveness of the non-pharmacological interventions like masking and all. But then, so after say 2 years or so, all the NPI measures were relaxed, and then the influenza made a comeback. And you can see that the peaks of influenza which happened over the last 1 year or so, the deep blue one is actually the H3N2. And last year, the more prevalent strain was H3N2, which is slowly being replaced by H1N1. And this is the data from the Southeast Asia region. Here also you can see that, now among the ILI testing, around 5% happens to be positive for influenza. And now in Southeast Asia region, H1N1 is becoming more predominant than H3N2. And the orange one is the influenza B. So today there was a report in the Times from this NIV Pune. They have said that in Maharashtra, around 96% of isolates are H3N2. But the Kerala story is a bit different. So this is from September 2022. Data from Kerala is around 1 year back. So at that time, the most prevalent strain in Kerala used to be H3N2. So we are having co-circulation of H3N2, H1N1 as well as influenza B. But by far, H3N2 was more than H1N1. But by around, say, February, March, when ICMR said that H3N2 is the predominant strain in India, by that time, the predominant strain in Kerala had become H1N1. So now we are having, say, co-circulation of H1N1, H3N2 as well as influenza B, but by far, majority of the isolates in the state happen to be H1N1, contrary to what is happening in Maharashtra. That is the importance of having our own data. And why is a syndromic approach important? Because we know that from the symptoms alone, it's very difficult to differentiate between SARS-CoV-2 infection, influenza, RSV, or to an extent adenovirus infection. So if we ask for one symptom which is basically different between influenza and COVID-19, it will be very difficult to say that. It's said that if you are having anosmia without rhinitis, it is likely to be COVID-19. Now, what are the outcome determinants? For a doctor, the most important thing is to have a very good risk stratification of patients. For the majority of the patients who are immunocompetent, healthy individuals who are vaccinated, so this ILA does not make much of a difference because the treatment is going to be supportive. So the outcome determinants are definitely the virulence factor of the virus, and we should be paying more attention to the host factors. That is a comorbidity profile as well as the vaccination status of the individual. And majority of us will be having hybrid immunity against SARS-CoV-2 like that. And pregnancy is a concern. So when we realize that we are having influenza circulation in the state, along with COVID-19, one advisory was given to all the gynecologists saying that if a pregnant lady is coming with ILI, you have to immediately start the patient on oseltamivir irrespective of the test result. The reason is that in third trimester of pregnancy, influenza could be a killer, like what we had in a very bad outbreak during 2016-17 among pregnant ladies and all. And the last aspect, that is the inoculum load. So inoculum load also decides the prognosis. So to bring down the inoculum load, the measure that we have with us is to use a mask properly. And we know that last year was the year of the pox, that we had the monkeypox in humans as well as the lumpy skin disease in animals. And this year it is referred to as the year of the influenza because the highly pathogenic avian influenza H5N1 is actually circulating across the globe, and around 12 to 15 human cases has also been reported. So when we are taking history about ILI, suppose the patient happens to be in touch with the poultry industry, so poultry or the duck farming, etc. So definitely the molecular diagnosis should be sought. Now this is one guidelines from the NIH regarding the co-circulation of influenza and COVID-19. So they say that definitely all of us are familiar with the ABC guidelines for influenza, where since it is endemic in Kerala, in India, so we are going for molecular diagnosis of influenza only in category C patients when we are suspecting complications like that. But the situation is not the same with COVID-19. So the NIH guidelines say that basically for all the hospitalized patients, we should be running both the molecular diagnostic tests for influenza and COVID-19. But for all the hospitalized patients, irrespective of the diagnosis, you need to start them on oseltamivir because oseltamivir is going to have a mortality benefit if it is started within 48 hours of symptom onset. And if the NAT is negative, you can stop oseltamivir like that. So based on this situation, so Kerala is lucky in one way because we had ABC guidelines for SARS-CoV-2 infection as well. So ABC guidelines for influenza in Kerala is same as the ABC guidelines for COVID-19. So an advisory was released 2 months back combining the COVID-19 and the influenza guidelines of the state. Basically, the ABC means that we need to stratify the patients. Category A patients, they are immunocompetent patients without any comorbidities. They are having the mild fever, cough like that. B1 means they are not having any comorbidities, but the symptoms are a bit severe, like high-grade fever, severe sore throat, etc. B2 means the category A symptoms in those with comorbidities, and category C means they are having the red flag signs which require hospitalization. So for category A patients, they don't require any specific antiviral as such. So these patients should be, if we have access to antigen testing for COVID, we can do that. If not, no issue, but then we should monitor them for development of red flag signs over the next 48 hours. Category B1 patients, if the COVID antigen is negative, start them on oseltamivir as early as possible. Category B2 patients also, if the antigen is negative, start them on oseltamivir. Category C, definitely we are going to hospitalize them and test them for both COVID-19 and SARS-CoV-2, but immediately we need to start them on oseltamivir, irrespective of waiting for the result. So why we are not starting everyone on oseltamivir? Important thing is that if you are going to start all the category A patients on oseltamivir, it will lead to oseltamivir resistance. So antiviral stewardship, just like antibacterial stewardship, is very, very important. Then what about patients with comorbidities having COVID-19 infection? Are we going to offer them anything? Are we going to offer them any drugs to prevent progression to severe disease? We have all experience with the monoclonal antibodies which are not useful because of the spike protein mutations, and the currently available monoclonal antibodies cannot neutralize the Omicron subvariant. So these are the drugs for use in patients with comorbidities having COVID-19 infection, which might prevent progression to severity. These are Paxlovid, Remdesivir, as well as Molnupiravir. All the three drugs are available in India. The evidence is not for Molnupiravir, so we can discuss between Paxlovid and Remdesivir. But the issue here is that the number needed to treat to prevent one hospitalization, looking at majority of us are vaccinated or having hybrid immunity, is going to be around 200. Suppose we are having a very immunocompromised patient, post-transplant recipient, extremes of this a person above 75, unvaccinated, etc. If they are having category B2 symptoms due to COVID-19, probably we can start them on Paxlovid or Remdesivir. Now the complications of influenza, we need to pay attention to two of them. So one is rhabdomyolysis. All the influenza can lead to myositis and lead to acute kidney injury, and the next one is encephalitis. Influenza can lead to influenza-associated encephalitis. So this prompted actually Government of Kerala to come out with the technical guidelines on influenza-associated encephalitis in children. The reason was that when someone is presenting with encephalitis, no one will think about influenza as the cause. They will be sending for CSF, biofare, herpes, and all those things. And this molecular diagnosis from the CSF won't check for influenza. So influenza can be associated with encephalopathy or encephalitis, and this can be picked up only from the nasopharyngeal swab. In SAT alone, we had around 20 kids who developed influenza-associated encephalitis, and that prompted the state government to come out with a technical guidelines on how to treat influenza-associated encephalitis. And since the progression was so rapid, at the presentation itself, the GCS is less than 8, so the guidelines say that you can have an institutional medical board and think about pulsing the patient with steroids. Now coming to the pan-ILA preparedness. So if we want to bring down the problems associated with ILA in the society, we need to screen everyone for diabetes and hypertension. That is what the state is doing through the Siley app. Optimize the BMI, optimize the glycemic status, the control of comorbidities. At least for patients who are vulnerable, those with comorbidities, etc., we have to focus on the non-pharmacology interventions, ventilation, etc. Obviously, the vaccination, COVID-19 as well as influenza, to an extent the severity can be reduced by vaccination. So these are the recommendations for influenza vaccination. Obviously, the people who are having the risk factors for disease progression are advised by WHO to take the flu shot. And this is with regard to the influenza vaccination timing. This is also very important. So every year, based on the circulating strains, WHO come out with the antigenic formulation. And India falls into the tropical Asia zone, and we are supposed to take the vaccine in April. Now I am opening the Pandora's box. RSV to us is actually a disease of the children. So if you go by data from CDC, every year they have around 1 lakh cases of RSV in adults, and this contributes to around 6,000 to 10,000 deaths due to RSV in adults. And this year, the FDA has around 3 months back 2 vaccines for use in people above 60 years of age. And they had this MEDICINA trial, the first vaccine to be given to a pregnant lady to prevent RSV in kids. Because during the COVID-19, what happened was that since all the mothers were shielded from the RSV, the kids were born without antibodies against RSV. So they came out with this MEDICINA trial, this vaccinating the pregnant ladies to prevent infants from developing RSV. And so basically in the West, the tackling ILA is about boosting with COVID vaccine, annual influenza vaccination, plus RSV vaccine for people above 60. They are creating sort of a vaccine wall for them. And the most important thing I would like to say is that majority of the ILIs in the country are being treated with the new vitamin A, that is azithromycin. This should not be done. So what will happen is that we know that 99% of ILIs are due to viruses. So if you are actually starting the patients on azithromycin, you can see that from 2000 to 2010, the azithromycin resistance in pneumococcus was around 4%. Now it is 40%. So azithromycin has become sort of virtually useless for the treatment of pneumococcus. So if you are starting a patient on azithromycin for ILI, we are actually missing the window of opportunity for starting oseltamivir if the patient happens to be immunocompromised. So thank you very much for this opportunity.
Thank you, Dr. Aravind, for this concise talk. Just curious to know, can you show a show of hands who have taken influenza vaccine in this crowd? Just curious. We're all healthcare workers. We come under high-risk category. Or,
we come in the high-risk category.
So hardly 6 of them I could see. So we are the actually advocates. So I actually request you all of you to take, because we carry infection, we transmit to many of the high-risk group patients also. It's an important vaccine. You will find the benefit, especially if you have one of the comorbidities, that the frequency has come down with vaccines every year. You will find the benefit, definitely. So I advocate that please take vaccine. Then you can promote among your patients. That's important. Especially, we find even children currently admitted for ECMO and severe ARDS and encephalitis. It's sad to say they die of influenza, which is preventable. And in pregnancy, you can give this vaccine in any trimester. That's the thing. So any trimester, don't leave that opportunity. In pregnancy, it's severe. Patient requires sometimes hospitalization and end up in ECMO. We have seen such cases. So please make protocols wherever you practice, so that if there is a protocol, nobody will have the inhibition and thinking whether to give vaccines. Thank you. So if there are any questions, we'll take it. Yeah, any time you can give. Don't lose the opportunity. There are 2 vaccines. You want to explain? The southern, northern hemisphere.
Actually, every year WHO convenes meeting in February to come out with the vaccine formulation for the northern hemisphere, and in September, October time to come out with the formulation for the southern hemisphere. And India means, in tropical areas, subtropical areas, there will be circulation of the influenza during the entire season. So there actually we have to decide the time based on our seasonal influenza activity. Since we are expecting monsoons by around say May, June, like that, ideally in India, means it's during the April that we are supposed to take. Okay.
Yeah, it's maybe a little different from Delhi or in northern part of India, where here the rains are the major thing, after which we have a thing. But we have another peak in winter also. So if you have lost an opportunity to give that vaccine in April to June, please give a vaccine anytime the patient comes to your OP next time.
Actually, when you are looking at the severe, it depends on the host factor as well. So I think we need to focus more on the host factors than on the virulence factors. Comparing H1N1 and H3N2, the ICMR advisory said that this year H3N2, the hospitalization rate was more than that of H1N1. The only thing is that the effectiveness of all these vaccines against H3N2 is around say 30% pooled prevalence. Okay, but against H1N1 is around 60%. So basically, the vaccine is a quadrivalent vaccine, but the protection against H3N2 during all these years have been only 50% compared to, means 50% less than the coverage for H1N1. So whether that is the reason why the hospitalization is more, we can't say that in India, because majority of us are not vaccinated.
Unvaccinated.
Yeah.
Just like COVID vaccine, the efficacy is to prevent the severity, and death. There may be mild illness, but definitely if you have found benefit from COVID vaccine and it has helped you to escape with a mild illness, same with influenza.
Thank you.